Welcome, everyone, to More Good Days, the official podcast of Haven Headache and Migraine Center. I'm your host, Neda Hindiyeh, founder and chief medical officer of Haven. Our podcast aims to help you stay informed about the latest research, policy updates, and most importantly, practical advice for managing life with headache and migraine disorders. This podcast offers valuable insights and support on your journey to achieving more good days. We started a 4-part series focusing on the topic of women and migraine, and in the last episode, we covered migraine, postpartum, and breastfeeding. This is the final installment of this series, but don't worry, we will integrate women's health into all of our episodes. And at Haven, we uniquely recognize the connection between women and migraine. For this series, Isaac and I are joined by Dr. Susan Hutchinson, who is a personal mentor and an amazing clinician, without whom Haven would not have been possible. She's a clinical director focusing on women's health. Her unique perspective comes from her background in primary care. Before helping to found Haven, she established the Orange County Headache and Migraine Center and authored a women's guide to managing migraine. A quick note before we dive in, we strive to ensure all statements in this podcast are clinically accurate, but it's not intended to be medical advice. Please review with your provider, or if you're in California, make an appointment with one of our headache specialists at havenheadache.com.
Before we get started on this episode, I want to acknowledge that we are using the term woman to refer to folks that experience menstrual cycles and pregnancy, perimenopause, and menopause in this series. However, we do acknowledge that there are many folks who do not identify as women who may experience these cycles of life.
Susan, thank you so much for joining us again for this final episode, and also another really important one because so many changes happen for women in this stage of life. Maybe to get us going, what are those big changes that we observe during this?
Thank you, Isaac and Ned. It's a pleasure to be with both of you. And this is an area that's just really near and dear to my heart, and that is women, hormones, and migraine. So when women start having menses, typically there's a regular cycle. It's fairly predictable of what happens with estrogen and progesterone. And on average, a woman has menses every 28 days. Now, when a woman gets into be her 40s, and around the average age of about 47 is often when what we call perimenopause begins. And I want to make a distinction between perimenopause and menopause. We often call perimenopause the change before the change. In perimenopause, the hormones are all over the place, so you don't have the regular cyclical fluctuations that when you're younger, you're used to. So often what happens when your estrogen and your progesterone are kind of all over the place, guess what? The migraines get all over the place. And the average time that a woman's in what we call perimenopause is about 4 years. Overall, generally, it's about age 47 to 51. That definitely can vary from woman to woman. So I think it's important for the listener and anyone to know, gosh, are my periods just really, really irregular and I'm still in perimenopause versus complete menopause?
And what happens between the transition, typically from a epidemiological perspective, with migraine? Does it increase, decrease during each of these phases?
Well, unfortunately, it often increases during perimenopause. And that's going to be particularly true for women that have this hormonal component. Because when you think about a younger woman, there's that predictable lowering of estrogen and progesterone just before menses. And because it's fairly predictable, a woman can often plan ahead and strategize. Unfortunately, in perimenopause, the periods can be closer together. They can be further apart. And it doesn't even make sense for a woman to be going in for hormone blood tests because it can change literally from hour to hour, from day to day. So because of these wild fluctuations in the hormones from the ovaries, unfortunately, migraine increases and sometimes fairly dramatically increases during this time of perimenopause.
What about after perimenopause? What happens then?
What we do, great question. So perimenopause, generally a woman is still having menses. They could be quite far apart, but she's still having enough estrogen activity from the ovaries to still be having that shedding of the lining of the uterus. Well, when a woman transitions to complete menopause, by definition, it's either a complete cessation of natural menses for at least 12 months, meaning that woman has not had a period in 12 months, or if a woman didn't want to wait 12 months, and this often happened in my practice, a woman would say, Dr. Hutchinson, I haven't had a period in 6 months. I'm getting some hot flashes. Do you think I could be going into menopause? We would do, here's where blood tests can be useful. And most useful is called an FSH and an estradiol level. FSH means follicle stimulating hormone. And that is going to be very elevated versus the estradiol very low during this menopause. And that's how you can make the definition. And I'm not going to give you numbers because that can vary depending on the laboratory. But in general, a low estradiol level and an elevated FSH can be another way to look and see if a woman is now entering menopause versus is she still in perimenopause.
And I know that, periods and the menstrual cycle will significantly change during that transition, but I understand there's a lot of other symptoms that can happen and other signs that you're heading towards menopause or that you're in perimenopause. Can you describe some of the signs and the changes that can happen?
Certainly. What we commonly think about, sometimes it's called vasomotor symptoms. Sometimes, unable to tolerate changes in like heat, hot and cold. But most typically we hear about hot flashes, night sweats, difficulty sleeping, irritability, fatigue. And I didn't used to know what that was until I went through it. And I remember when I was younger, women would talk about it and I thought, well, that doesn't sound so bad. Well, it is when you're going through it. Just imagine you're at a meeting, and this happened to me one time. I was at a hospital, and I was the only female in the room at some big hospital meeting. And all of a sudden, I had this hot flash, and it just kind of went through me, and I got really red. And so probably the others thought, oh, she must be embarrassed about something. No, it was a hot flash, and it was really uncomfortable. And what's interesting, too, there's often sleep disturbances during this time. And sometimes it can be rather comical because women want the bedroom typically a lot colder than, let's say, if she was married. And then so often this can be problems in the bedroom because the woman might be leaving to go into another room where it's cooler. So it can be a very challenging time. And then the other thing, just to add to it, a lot of women are also facing sometimes a little bit of loneliness because their kids are often away at college. And if the woman has devoted her life to raising her family, just imagine her children don't seem to need her as much, and all of a sudden she's feeling miserable, and maybe her husband doesn't understand. So guess what? You may then have depression and anxiety. So I think this is a very vulnerable time, and we never want to treat a person just for their headache. I mean, I think we look at, the patient, the person, that yes, you may be having more migraines during this time, but what else is happening? Is there depression? Is there insomnia? Hot flashes, night sweats. So we really want to try to treat and look at the whole experience of perimenopause and menopause.
It's a lot of changes to go through. And do you see some of these symptoms improving once a woman is in menopause?
Yes, unfortunately, not everyone, but in general, about 2/3 of women, when they go into, again, I call it complete menopause, but again, it's where the ovaries are no longer doing the up and down in estrogen and progesterone. So when a woman goes into complete menopause, about 2/3 will get marked improvement. And some, their migraines may even go away, particularly if their main trigger prior to menopause was hormonal. Because when you think about it, all of a sudden she's not getting the ups and downs, and the estrogen progesterone are very low. So that can be very beneficial for some women. Sadly enough, though, some women can't wait to be menopausal. And for some, their migraines continue. And why is that? Well, there's many other triggers, right? Because you removed the hormonal trigger, but what about stress, lack of sleep, change in barometric pressure, dietary trigger? You still have all those other triggers.
Do some women actually start the beginning of true menopause as well?
If a woman were to start having new onset migraine at the time of menopause, it can happen, but I certainly think that woman needs a workup for what we call a secondary headache, because it's very unusual for someone all of a sudden to start having new onset migraine after the age of 50.
And what about for women who end up entering menopause because of a hysterectomy or cancer or some other physiological reason?
Yes, that's a great point. If a woman is thrown into menopause, let's say she has a complete hysterectomy, and let me also make sure we differentiate between when a woman just has her uterus taken out. Let's say she has a big fibroid tumor, but it's not cancer. If the ovaries are left in, she will continue to have the estrogen and progesterone. So she could continue to have, we couldn't call it menstrual migraine, but you might call it a hormonal migraine. So remember, because the ovaries are still in. It's a little bit different if a woman has a complete hysterectomy in which both ovaries and the uterus are removed. It really throws her into menopause. And that's a very sudden experience. So that definitely could really wreak havoc with migraine control. Because if a woman gradually goes into menopause spontaneously, it's a little bit easier on her system and her migraine pattern. If you're thrown into it, so if I had a patient and I knew she needed a complete hysterectomy, let's say because of cancer, I'm going to really make sure that I've got a great preventive strategy on board, both before and after the surgery, to try to help minimize that incredible potential exacerbation of migraine.
I've had some patients actually come in asking about, well, do you think a hysterectomy would help my headache if I did it now at, at a younger age? What do you think about that?
Completely disagree with it. And I've had countless women, they just say, take it all out. They're
Yeah.
so frustrated. I was like, no. There's a lot we can do. And just to throw you an example, in women that are perimenopausal, even if they don't need birth control, let's say their husband's had a vasectomy or they've had a tubal ligation, even those women could potentially be treated hormonally. And I'll say, look, we can kind of mimic what would happen with a hysterectomy if we give you continuous low dose birth control pills. In a sense, we're putting your ovaries to sleep. And let's see if that helps. So I would much rather do that, Netta and Isaac, than to have women go in for something like a hysterectomy and then later regret it.
I totally agree.
What are the biggest differences in treating younger folks versus or young women versus those who are in this perimenopause and menopausal state? Or are there any?
Yeah, great point. In younger women, if they're having regular menses, you can really plan ahead. You could have a short-term preventive strategy with one of the long-acting triptans like naratriptan or frovatriptan. You often can do the continuous low-dose birth control pills. You've probably heard the saying, it's the devil you know. So if a woman has predictable menstrual migraines, I think it's a lot easier to manage. The problem with perimenopause, it's just all over the place. So the woman's like, gosh, this short-term preventive strategy that I used to do, I can't because I can't predict. And it can be extremely frustrating. So I think for the woman who's perimenopausal, I'm probably going to recommend a preventive approach that isn't so targeted because we don't know when menses is. So I personally think some of the wonderful CGRP targeted preventive treatments we have, whether it be an injectable, the IV, or oral, I think that could be a really good way to help with prevention during that vulnerable time.
Yeah, I often tell women that come to see me that when they're kind of nearing their mid 40s, I tell them this is truly going to be the worst time for migraine. So it's really important to get that prevention in place. And I know we touched a little bit about hormone treatments, but what role do you feel hormone replacement therapy plays in migraine, if any?
Yeah, that's also a very good point. I think what I want the listener and all of us to remember is that hormones are not the number one preventive for a woman who's perimenopausal and struggling. The hormones, they may or may not help. So I think you still want to look at the more migraine specific medications, like I mentioned, the CGRP targeted treatments, which, by the way, the American Headache Society that we're all quite involved in 2024, they published guidelines recommending that patients be allowed to take these specific CGRP treatments without having to go through generic preventives. So going back to the hormone issue, I think the main reason to take hormones would be if a woman's got everything else, she's doing everything else, but she's still frustrated, particularly if she has bothersome hot flashes, night sweats, vaginal dryness, or perhaps she's at risk for osteoporosis. So there's specific reasons in which hormones would make more sense, but I don't think it should be the only preventive that a woman takes when she's perimenopausal and having migraines?
The science has really changed around HRT in the last few years. While you said it isn't necessarily the only migraine treatment, it probably is helpful to understand what that science has changed too in the last few years for listeners who may be still kind of a myth around HRT. You talk a little bit about what has changed in the last few years with perimenopause care.
I certainly can. I was working for 8 years in an OB-GYN practice, and they brought me on board to, handle the headaches and the depression, the family medicine issues. So I was also doing a lot of well-woman exams and pap smears and hormone therapy. I will never forget that fateful day when they announced the results of the Women's Health Initiative, WHI, and it came out showing a lot of risk. But I think what's important, because that study has really been criticized, they were only looking at women who were on Premarin and Provera. Premarin comes from pregnant mares. That's where they got the name Premarin. It is not bioidentical. It's not the same as when we talk about estradiol. So I think it was really unfair when all these conclusions were made when it was just looking at Premarin and Provera. And we've really moved away from those two hormones. So I think the pendulum is swinging back, but back then, the Women's Health Initiative, a lot of women were so scared. Healthcare providers were frightened. So there was a really, I think, kind of an overreaction to that Women's Health Initiative and just taking women off hormones. And then gradually the pendulum swung back. But I think now the general guideline is if a woman needs hormones to only maybe do it for 3 to 5 years, the first 3 to 5 years of perimenopause/menopause. So before I joined Haven, and I was still very active in women's health, I was very open to prescribing a natural estradiol, usually in the form of a patch, and we might do a micronized natural oral progesterone tablet or capsule that she took at night, but we would reevaluate every year to see if it still made sense.
Yeah, that makes complete sense. We want to be careful with these options. So do you think when we're looking at medications in general for migraine in this time period, are there particular medications that you would want to avoid because they don't work as well, or particular medications you would generally use because they tend to work better?
Well, let me put a plug in for one that I think can be very useful during this time, and it's called venlafaxine, which is Effexor, or duloxetine, which is Cymbalta. These are SNRIs, so they help to regulate serotonin and norepinephrine. And low-dose venlafaxine, which is Effexor, has been shown to reduce hot flashes and night sweats. Both of these are also FDA approved for anxiety and depression. Because in addition to an increase in migraine, I often see women having also more depression and anxiety. So I would lean towards those. I think I would avoid both topiramate, which is Topamax, and Depakote, which is valproic acid, because Depakote can cause weight gain, nausea, tremor. The topiramate can cause word retrieval issues, and women are already struggling. And so if they're in that time of life, I would not recommend topiramate, in which they're having trouble remembering, and that's going to increase their frustration. There's other side effects of topiramate. So I think I would avoid the anti-epileptics. The antihypertensives, which are the blood pressure medication, may be useful if the woman also, if her blood pressure was creeping up. And personally, I think the one that's really showing a lot of good evidence now is candesartan, which is an ARB, and it doesn't have the burden of the side effect of the beta blockers, which often can be sedating. So I think the ones I would lean towards would be the venlafaxine, duloxetine, or candesartan.
And would you still also then consider the newer therapies, the CGRP therapies, and also something like Botox if they're having chronic migraine?
Oh, yes, absolutely. I didn't mean to take away. That would be the mainstay. I think these other ones I mentioned would be in addition to that foundation of really blocking CGRP, because we know that's just a major neuropeptide. I think if the woman had chronic migraine based on 15 or more days a month for over 3 months, certainly Botox. And of course, in your more refractory patients, I would be very open to having a woman have Botox and be on one of the CGRP targeted therapies, and then if necessary, adding something like the venlafaxine or duloxetine.
I totally agree. I think that's a strategy I use now with a lot of my patients.
And you know what I tend to do too, Isaac, and that is I reassure these women, look, I know you're probably frustrated now because you probably feel like you're doing everything you can, because many of these women, they exercise, they eat healthy, and they feel like, gosh darn. I try to tell them, look, this is a temporary time in your life. We often have to be on more medication and get more aggressive. But when you become completely menopausal, and I explain to them what that is, then we can relook at these treatments and maybe we can back off from some of them. Because that has been my experience for the majority of women when they get into complete menopause. Maybe they don't need to be on as many medication, and maybe we can be a little bit less aggressive.
I like that strategy. And what about natural supplements or any options in that category that may be helpful in reducing symptoms?
Yes, I think when you look at those that have the most evidence, it would be things like black cohosh, red clover, and soy. But be careful with soy if you have any sort of an estrogen sensitive cancer. So be careful. But those are kind of the category we call phytoestrogens. They're natural supplements that aren't estrogen, but they have estrogen like activity. Also, there's some that are actually prescription strength. And I think one was from a Swedish flower extract, and I think it's called Relizen, like Relize. And I can't remember if it's over the counter prescription, but there are increasingly some medications that are actually for hot flashes that have a natural origin. So I think if someone said, I'm trying the black cohosh and red clover, it's not cutting it. I can't take estrogen because of breast cancer. There are, new medications that are coming out that can help.
That's very interesting. I actually I didn't know these were options for women at that time. Who should the women ask about? Should they ask their primary care about these or their OB-GYN? Who would have more details here?
I think that can be really dependent on the nature of the primary care of the GYN. And I'll give you a couple examples. Someone with migraine is going to a female family physician, internal medicine. That person may already be doing their gynecological care. And I think that would be a good place to start. If, on the other hand, you are going to an OB-GYN office and they're the one managing your, whether it be hormones, contraceptive, your well woman exam, then I would ask them. Because what I am finding more and more is there are OB-GYN groups in which some of the OB-GYNs don't even deliver babies anymore. They do more GYN. So one thing would be to ask in a big group, are there any of the OB-GYNs here that are just focusing on GYN? Because some even go back for extra training. I think either one, but I think it's going to mean that the person with migraine that has questions about hormones, you need to ask and you need to find out which provider in that group, whether it be a family medicine group, internal medicine, or OB-GYN, which one, and the receptionist would know or the nurses would know. They will often tell you who they think would be best suited for that. So don't be afraid to speak up and ask.
Yeah, it's really important to advocate for what you want to try as well as a patient. And any kind of final thoughts or advice for anyone getting care outside of Haven or even in a typical neurology office?
I think I would just encourage everyone to educate yourself. One of the organizations that has helped me a lot is North American Menopause Society, and that's a free website. And I believe the website is menopause.org. And you can go and get a lot of good information about hormones. You can be, refreshed on what would be the indications for considering hormones. So I would just say menopause.org. And just do as much reading as you can. Talk to other women in your age group, see what they're doing. And I think the more knowledge all of us have when we go for any doctor's appointment, when I say doctor, healthcare provider, it could be a nurse practitioner, PA, the more educated we are, I think the more valuable any of those appointments become.
And while not headache specific, there are some good options for people now online, such as MIDI Health, that specialize in this sort of women's midlife care. If you are running out of options locally, and many of them have too.
Thanks, Isaac. That's really good to know.
And so much for joining us. I learned so much about a woman's journey throughout life and headache care. So thank you so much for teaching us.
Oh, it's nice, even as I get quite old. It's nice to still feel like I can make a difference.